I'll be talking about the experience in Kenya and East Africa. So to start with, this is a map just to show us which region we're talking about. So this is East Africa. That includes Kenya, Tanzania, Uganda, Rwanda, and Burundi, and maybe South Sudan, with a population of almost 200 million people in this region. This is a paper that was published in 2020, and this map shows the global distribution of PID prevalence based on cases reported per 100,000 individuals. And when we look at sub-Saharan Africa, it's in gray color. And from this paper, the gray color basically meant that there's no registry, no published report, so there's nothing known about inborn errors of immunity in this region. This is the Kenyan journey of PIDs. Our first reported case was in 2014. This was an autopsy-based case report from a family that basically had lost 3 children. So this was a child baby who had died in early infancy, and they actually wanted answers. Why are the children dying? Why are the babies dying? So a postmortem was performed by my colleague, and from the postmortem report, he actually suspected a DiGeorge syndrome because there was no thymus. Then things were pretty quiet for about 4 years until 2018 when we held our first A project. This was hosted by Dr. Angela Mligoa, who's a pediatric rheumatologist, and it was during the annual Kenya Pediatric Association conference. At about the same time, we had lost another patient to a suspected PID, a suspected SCID. So the parents of this patient went ahead and formed our patient group. It's called PIDs Kenya. From then on, we had another A project in 2019, second A project. The first one had maybe about 30 attendees, second one about 60 attendees, so it was bigger. In 2020, we held a third A project. This was during COVID, so we held it in form of an online webinar, 2 hours from 6 to 8 p.m. over a period of 3 days. We invited Nahla, as she was the then president. It was a very well attended seminar with up to 1,000 attendees attending every single day. So what was the impact of these A projects in Kenya? One, there was increased local awareness. People now do consider inborn errors of immunity as a diagnosis. So there was also increased referrals of patients suspected of IEIs, majorly children with recurrent infections. We made new diagnoses, and 3 other publications came out of this. This was a publication in 2021, a baby who had presented with persistent oral thrush and disseminated basidiosis. This was a case series from a private pediatric hospital of 3 patients with a SCID phenotype, both clinical and a lab phenotype, though there was no genetic diagnosis. And this was a case report published this year. I would say this was maybe the first success story because these other children all passed on, but this third one ended up having a bone marrow transplant late last year. So current status, from the time we started having these A projects to today, we have a cohort of about 11 children that are either suspected or diagnosed. They consist of 8 males and 3 females. The age at diagnosis was variable, ranging from birth to 10 years of age. All these children presented with a history of recurrent infections, except for one who was now a sibling to one of the cases that passed on from the case series that was reported. So at the time, this was a child to a parent who had parents who had 3 babies who had died, and we had the first lymphocyte subset enumeration performed in 2019. This was sent out. When the results came back, the baby had already died, but the parents were explained to the results and what the likely diagnosis was, and they were told, when you have another child, please report to us and we can tell you what to do, how we can screen this child. So this is how we had a child who was basically tested. They went ahead and did a genetic test, which showed a JAK3 mutation, and this was done in India. And after consideration of the family history, and the previous infant losses, the team in India decided to go ahead and perform another bone marrow transplant. So that's our second success story. So from this cohort of 11 children, 8 have a family history of recurrent infections and early sibling loss, and consanguinity has only been reported in 1 case, so not very common in our region. So from this cohort of patients, these are the categories of inborn errors of immunity that we have. We have 3 cases of SCID, 2 confirmed, 1 not yet having a genetic test, 1 confirmed hyper IgE syndrome. We have 3 antibody deficiencies. 1 has a genetic diagnosis. The other 2 we actually still suspecting that it could be a transient hypogammaglobulinemia. Then we have 3 confirmed phagocyte defects and 1 properdine deficiency. What are the outcomes from the current patients? So out of this cohort of 11, 9 are alive, 7 are still on follow-up with supportive management. They haven't received definitive treatment. 2 have had definitive treatment. I think I've alluded to those cases. They had bone marrow transplant performed abroad. So what is available in Kenya in terms of diagnosis and management? So we do have these screening tests. In our region, when we suspect an immune deficiency, we always have to rule out HIV first. So we'll do a serology or PCR, depending on the age of the patient. Complete blood counts are widely available in all hospitals in the region. The total serum immunoglobulins are only available in Nairobi, which is the major capital center, and only in the private hospitals or in private labs, so not in the public hospitals. Basic flow cytometry is now available, basically only T and B cell enumeration. We perform this at a private hospital that is performing flow cytometry for immunophenotyping of leukemias. So they're only able to count the T and B cells. They haven't validated the NK cell enumeration. So if we need the 3, we'll send out to India or to South Africa. But at least we can do the T and the B. In terms of confirmatory testing, we basically rely on genetic testing that is sent out to India. We have no local lab that performs sequencing. And this is quite expensive, so not accessible to all patients, especially if they don't have private insurance. So we have no capacity for specialized testing like advanced flow cytometry or functional assays, so we never consider those. And in terms of management options, prophylactic antimicrobials are widely available. IVIG is available, quite expensive, but it's covered by our national health insurance scheme. And adjuvant therapies such as GCSF is available. How about definitive treatment? Hematopoietic stem cell transplant, we send out patients. We did perform our first transplant in the country last year, although it was an autologous transplant for a patient with multiple myeloma. So hopefully going into the future, once they go into allogeneic, we'll be able to perform bone marrow transplant for immune reconstitution. Gene therapy is not available or accessible to us. So our challenges are basically inequity in terms of access to diagnosis, and this is the major limiting factor here is the cost. So these tests are quite expensive for patients who don't have private insurance, especially the genetic testing. The other experience we've had with genetic testing is sometimes we do get, so from the cohort I've shown you, those are the ones we really think do have PIDs, even if they don't have a genetic test. But there's another group of patients who, have a phenotype of recurrent infections. Some have had genetic tests that come back with variants of uncertain significance that becomes really difficult to interpret and put all that information together. We do have a pediatric geneticist, but still, for some of these cases, we are unable to really confirm whether these are significant variants that we're finding. The other major challenge is low access to treatment. There are a few number of specialists or dedicated personnel. I want to say that really we don't have clinical immunology as a special or dedicated training in our country. So we really don't have clinical immunologists. Even if I dabble in that area, I'm really a clinical pathologist. And my department is not really a clinical immunology department. All the specialists who take care of these patients, and I'll show you at least in the acknowledgement, are based in Nairobi. So outside of Nairobi, there's really no one who is interested in this area or taking care of patients suspected of IEIs. In terms of treatment, cost is also a major limiting factor. Okay, how about the rest of East Africa? I've talked about the story in Kenya. So I performed a literature search, and this is what I was able to find from Tanzania. They have 2 case reports, which are pretty recent, one in 2021 and one in 2022 on Wiskott-Aldrich syndrome. Okay, so at least there's some activity going on there. There's some knowledge in this area, but we really don't have much more information of what else is happening in Tanzania. In Uganda, I came across this review that was talking about the challenges in diagnosis of primary immunodeficiencies and potential solutions of how these patients can be found. So at least they're talking about primary immune deficiencies in this region. I was not able to find anything from Rwanda and Burundi, although I was happy to meet a doctor from Burundi in this conference, and I was not able to find anything from South Sudan. For Ethiopia, I'm not really sure whether they're included in East Africa, but I do know they've had some case reports of some inborn errors of immunity. So there's some activity going on there. So the major concerns is that it's likely that there's underreporting of cases of inborn errors of immunity within the East African region. And this is because many cases probably do remain undiagnosed. From the list I've shown you, the SCIDs, the Wiskott-Aldrich, this would be rare inborn errors of immunity. So where are the more common ones? Where are the antibody deficiencies? We still don't know. We don't have registries in this region, which is another challenge. So it's likely that there's still reduced awareness. And when there's no awareness, then an inborn error of immunity will not be considered as a diagnosis, okay? So even for our infectious disease team, when a child is presenting with recurrent infections, the first thing they'll think about is HIV, perform a test, and then they'll start empirical therapy for tuberculosis, because the major manifestation in these children will be recurrent pneumonias. So in my region, they would still think of TB before even considering that it could be an inborn error of immunity. So what are the potential solutions and future initiatives? We still need to continue having these A projects. We still need to continue creating awareness, to educate and train the medical personnel, and probably do this in collaboration with ACID, industry, and patient groups. The other thing I'll mention is that as much as we have a patient group, there's been difficulty recruiting patients. And I think it could be something cultural, because generally Kenyans don't want to be associated with disease. So they think, if they're seen taking part in patient advocacy, people will, label them as having this particular disease. The other avenue would be to look at sustainable funding for diagnosis, especially offering the immunological tests, probably borrowing from what Prof. Tandaka has talked about, collaboration with existing infectious disease programs. We initially thought, for example, for flow cytometry, we can, just add additional antibodies into the CD4 counting, but our government has now stopped CD4 counts to monitor HIV and is only funding viral loads. So it's been difficult to get into that. The other sustainable avenue would be lobbying through patient groups. I think yesterday we talked about how strong patient advocacy is. The governments would probably listen to the patients more than listening to the medical fraternity. The third thing would be implementation of WHO Essential Diagnostics List. So in Kenya, the Essential Medicines List has been adopted. They're currently working on the Essential Diagnostic List. I had looked at it. It had been sent to me a couple of months ago. They took out the TB and K enumeration, which is provided for in the the WHO list. And then they had a separate page where they were talking about infectious diseases of concern, mainly pneumonia, recurrent diarrhea. And so I brought back the list and tried to justify that, these are the patients who are going to present with these infections that are of concern. So it would be good to be able to pick up these patients. So I hope they're going to adopt that and probably implement it, and we'll have widely available screening tests. The other solution would be to look at adopting ACID guidelines or developing local guidelines using clinical phenotypes that are relevant to us and considering infectious endemic disease, and probably sharing those guidelines within the East African region so that every country is involved. The other avenue would be networking and collaborations to help with diagnosis and treatment, working with countries that have these more advanced tests available and seeing how we can cooperate. And definitely, I think we need to work on establishing national registries and centers of excellence for both diagnosis and treatment so that we can have better outcomes and more success stories. So in summary and to conclude, there has been some improvement in diagnosis. I think if another global map is drawn, there should be more color within the East African region or in sub-Saharan Africa. However, we need more efforts to reflect the true prevalence. There's still inequalities in access to diagnosis and treatment. So in future, we need to continue awareness creation and training, engage with key stakeholders on sustainable funding for equity in diagnosis and management, and collaborate with more specialized centers. So I would like to acknowledge this team of doctors. This is the team of doctors that is currently involved in the field of PID screening. So, many pediatricians, mainly from pulmonology and infectious disease and hematology. And then I have 2 clinical pathology colleagues. I would like to acknowledge ACID because this would not be possible without collaboration from ACID. And the major treatment centers are Kenyatta National Hospital, which is the largest teaching and referral hospital in Kenya. It's a public hospital. And then we have 2 private hospitals, Aga Khan University and Gertrude's Children's Hospital.